Okay, hi everybody. Thanks for joining. Today is August 3rd, 2021, and this is the fifth part of our six-part telehealth webinar series. Today's, actually I'm supposed to be sharing my screen, one second. There we go. Today's learning objectives are that after participating in this event, participants will be able to define what telebehavioral health consists of and how it's different from telemental health, state what a telebehavioral health visit looks like for a patient, recall data and evidence related to the effectiveness of telebehavioral health, identify the opportunities and challenges of implementing and sustaining telebehavioral health for rural health providers, describe how COVID is affecting and may affect telebehavioral health as a service line, and finally, summarize examples of how flex programs can support telebehavioral health initiatives. So, share my screen. And with that, go ahead and introduce our speakers. So, Jonathan Neufeld, PhD, is the Program Director and Principal Investigator of the Great Plains Telehealth Resource Center, Telehealth Resource and Assistance Center, or GP track, a federally funded technical assistance program housed at the University of Minnesota Institute for Health Informatics. The center provides telehealth training and consultation to healthcare providers and programs interested in implementing, evaluating, and enhancing all types of telehealth services in the Great Plains region. Dr. Neufeld has consulted on a wide range of projects related to rural health and telehealth over the past 15 years. He has presented at regional and national conferences and published peer-reviewed articles in the fields of telemedicine, clinical decision support tools, mental health services, evaluation, and clinical outcomes. Dr. Evelyn Nelson of University of Kansas Medical Center is joining Jonathan, and she's going to just speak briefly towards the end of the webinar. But no worries, we'll have her on the next webinar, which is going to be a follow-up to this one, and we'll introduce her more fully then. So with that, I will turn it over to you.
All right, thank you, Nicole. Okay. We are going to talk about telehealth for rural providers today. Like they used to say in college, if you expected a different webinar, you're in the wrong room. I'll give you a little outline, and I'm going to talk a little bit about who we are as TRCs. TRCs tend to talk about we a lot because there are 14 of us, and I'll give you a little bit of an overview. I'm at one of them here at the University of Minnesota, but there are 13 others across the country, including the one that Evelyn heads up. And I'm just going to do a quick overview of what happened the last year and a half and how it's impacted telehealth. Then I'll lay a sort of a groundwork, some kind of framework of regulatory issues, because what you need to know about implementing telehealth has everything to do with about how it is regulated and conceptualized as a legal and clinical event or a series of events. We'll talk a little bit about implementation and some of the things that you need to be aware of in implementing telehealth, and then some service delivery and clinical skills. We then will, I don't think we'll have any clinical examples today, although we can talk about some of those in the Q&A. I think we're putting those into the next session, but we should have ample time for Q&A at the end, and really do want to hear your questions. All along the way, I will make an effort to relate this specifically to the rural providers. And, you know, it's as much, telehealth is just such a regulatory beast. I mean, it's what it can and can't do, what it does and doesn't do, what you can and can't do with it is so much related to the regulations around it. And prior to the pandemic, and probably after the pandemic, the regulations around telehealth varied so much. Every payer could have different policies. Every state could have different policies. The federal government, of course, had its own set of rules on the one hand and coverages on the other. And so there's just a whole lot of variation. it may not matter so much about rural and urban as much as what sort of an entity, legal entity you are. Are you RHC, or you critical access hospital, or you an FQHC, or just a freestanding clinic, or have some other sort of designation, because the way you get paid changes a lot of how you can or can't do, or at least can or can't get paid for telehealth. All right, so I'm going to hustle through a lot of this. As I said before, there are 14 of us telehealth resource centers. We're all funded by the federal government. We don't work for the federal government, but our grants come from that, and these projects come from that. I cover these 6 states in the north central part of the country, but other groups cover other states. We also have 2 national centers, and you can see on the right side there, in the light orange box, TTAC, that covers the Telehealth Technology Assessment Center, that covers technology in depth, and then the Center for Connected Health Policy, that covers policy in depth across the country. So those are the TRCs. Everything that we do, almost 99.9% of everything we do is free. So reach out to us, go to that national website at the top, www.telehealthresourcecenters.org. Center or centers, plural or singular, doesn't matter, we own them both. You'll get to our website, and it will direct you from there to any of the other TRCs, and you're welcome to reach out to any of them, myself included. GP Track is there, along with Heartland, where Evelyn and Robert are, and as well as all of the other TRCs across the country. Fabulous resources there, and I'll probably mention a little bit about them more as we go through. Of course, as you know, the last year changed everything in the world of telehealth, almost everything, and we're going to see how much of it changes back. But telehealth was a nice to have thing, but it now is a baseline expectation of all of us. In the words of the Agency for Healthcare Research and Quality, it's not just a niche option anymore, and it has become just sort of bread and butter. You have to be able to do telehealth, even if you don't have to do it today or this week or with this patient group, or right now patients can all come in to the clinic. Still, it is something that you would be remiss not to have skills around, competencies around. So that has all happened because of COVID-19. This is the Nike swoosh of 2020. I'm sorry, 2020, I said 2019 just before. This is what it looked like from one large multi-payer data set. We're doing a review of multi-payer data set studies right now, and realizing there is no nationally representative sample. These are all sort of mega-sized convenience samples, because we don't have a nationally representative sample of claims data. But this is what happened in middle of March. Encounters just fell off, and at the same time, telehealth visits jumped to try and fill that gap. As it turns out, primary care visits at least fell by about 50%. And of the 50% that was being done, about half of that, 25% of what would be normal, but 50% of what was happening at the time, turned out to be telehealth. And then that telehealth tapered off again. We had a sort of a stable period. And now we're sort of into a period of stabilizing. And that's what this graph shows. The gray is the in-person visits, the yellow, orange there is telehealth visits, is total visits. The blue is telehealth visits. So you can see as the in-person visits fell, the blue telehealth visits jumped, and together they added up to the orange line, so that we didn't have quite as big a dip as we would have had. A couple of things that we learned about that, though, as we're starting to look at these data, is that even though telehealth was always, or for a long time, was touted as a kind of a rural thing, savior of the rural area, we did way more telehealth in urban areas than rural. And I think that's just because there's more healthcare being done in urban areas than rural, more resources there, and everybody had to face COVID, and COVID hit harder and faster in urban areas. And so they jumped into the telehealth space a little more enthusiastically than those of us in rural areas. And that has continued to be the case. That rural-urban distinction has not been the real, it has been backwards. In other words, the rural folks are still doing less telehealth than the urban folks. The bigger distinctions are in other areas. Another source of variation is age. It varies by population, patient population. Early on, parents kept their kids home, but it rebounded a bit. And then adults ultimately, though, did more telehealth than kids during the first half of 2020. Specialties responded differently. Not every specialty works great with telehealth, and so we didn't see the same adoption. Interestingly, the telebehavioral health or the telehealth, telemental health, that blue line, green line in there, those didn't fall as far, but also didn't rebound as robustly. So we do have some variation there by specialty. This is another look at specialties and how much they recovered by the end of the year relative to a baseline in early March. And the interesting thing is that even though behavioral health, a lot of telebehavioral health was done, overall behavioral health visits, at least in this large multi-payer, I mean, these are tens of millions of claims. This large data set, behavioral health was still down 10% relative to its volume at the beginning on a week-by-week basis. The weekly volumes were still down by 10%. Weekly volumes in pediatrics were down by 24%. Adult primary care had actually rebounded. And I think we were making up some ground in primary care. And I think we kind of figured out that we could do primary care using telehealth. And so that's where the need was. And so that's where we applied a lot of our efforts. And then, like I said before, organizational type and legal issues. And also, I think mission and focus is going to matter a lot going forward. FQHCs appear to be doing a higher percentage of telehealth than other types of organizations, at least early on. So we will see how that continues to develop. Telehealth can be viewed as a fairly modern phenomenon, but as you can see by the pictures here, it actually goes back quite a ways. Early on, 50s and 60s, we were already doing telepsychiatry using state-of-the-art equipment of the day. By the mid-70s, here is a fairly significant report that was written about 1,000 encounters, and the findings were basically telehealth works. Telediagnosis, he called it, but telehealth worked great and is a great way to extend access. Now, he was doing it with this equipment, but he being Kenneth Bird here is the guy in the picture, and he was kind of the great-grandfather of telehealth at Harvard. But there was a lot of enthusiasm already for telehealth back then, and we have way better technology now, as you can tell. Change happens over the years, and I just wanted to point out, by way of getting into the research, that the volume of telehealth was driven by policy changes. Medicare started in the mid-90s, started paying for telehealth, and a whole era of research and utilization sort of built on Medicare's coverage. It was primarily specially focused and in rural areas, as Medicare originally was intended. During the 2010s, networking, ubiquitous networking became a thing, as well as tremendous strides in hardware and software. And so a lot of factors emerged to make telehealth much more possible during that decade. But it took COVID-19 to really launch telehealth, as you all know. This is just the number of citations in PubMed with telehealth or telemental health or telemedicine, telebehavioral, these terms, how often they show up in the PubMed citation database. And as you can see, the jump there, the beginning is where Medicare starts. A couple of jumps around 3G and 4G rollout. And then, of course, COVID-19 in 2020 has created another sort of launch there. Primary findings, and I'm summarizing thousands of studies here, literally thousands of studies of telehealth. And this is my own sort of editorial summary, not a systematic review by any means, but when telehealth is used to meet patient access needs, patients love it, okay? We wonder about satisfaction, but the thing we don't take into account is usually we're not saying, oh, no, don't see the doctor in person, see the doctor by video, which would be a kind of a disappointing letdown. What we're actually saying is, oh, if you can't see the doctor at all, try telehealth. We'll get you in to see the doctor this way. And patients say, oh, great, I can see the doctor. They don't say, oh, great, telehealth. They say, oh, great, I can see the doctor. And so because of that, patients are very, very satisfied with access to care. Are they satisfied with telehealth? Well, it is what it is. It's kind of like, do I want my kids to call me on my birthday rather than show up in person? Well, no, I'd rather they show up in person, but when they don't show up in person, they call me, and that's good too. And I think that going forward, we're going to have to continue to realize that telehealth is we're not trying to replace all healthcare with virtualization. What we're trying to do is use virtualization when we can't be in person. And there are many things for which we will never be in person. I mean, think about rural telestroke care. You're never going to have an interventional neurologist standing in every rural emergency room, ready to go, just waiting for a call, right? Not going to happen. You're going to have to use telestroke to provide that level of coverage for all of those rural areas. And there are lots of other ways in which we're going to have to do that. A second point, treatment outcomes, for the most part, are indistinguishable from in-person care, okay? Treatment outcomes in telehealth are indistinguishable from in-person care, partly because we don't measure outcome really fine in a fine-grained way. That's just the reality of healthcare. But the other thing to recognize is that providers are always working to make sure that treatments succeed, and they don't try unreasonable things. They're not trying to do vaccinations by video and failing. They're trying to do things that they are fairly confident that they can do. And so it's no surprise that treatment outcomes are good with telehealth. In fact, they're indistinguishable from in-person care when they can be compared, apples to apples. Telehealth can be used to save a lot of time, a lot of travel, and a lot of money. It doesn't automatically lead to those savings. This is a point that I think gets overstretched a lot of times, because telehealth does not automatically make you a better doctor or a more efficient healthcare system. It is a way to do those things, just like using the telephone doesn't automatically make me a better parent, but there are times when a well-timed phone call and I say the right thing gets me a lot of good parenting points, right? Same thing with telehealth. It does not automatically make us more effective or efficient, but it can be used to be more effective and more efficient if it's used judiciously, and we're constantly trying to do that. Consensus findings too, these are kind of outside of the empirical realm, but telehealth in general is seen as more appropriate in some situations than others. And I will say that there is no specific patient or treatment group that's been definitively ruled out. And as soon as you say, oh, telehealth doesn't work with this population, there's somebody somewhere very creatively and energetically working to serve that population using some kind of virtual care. And it is purely a matter of, the innovative work and hard work of those clinicians using virtual care. It doesn't just automatically happen. And the same, sort of by the same token, professional and ethical standards still apply, but with some new implications, obviously. So let's talk about the policy framework. Behavioral health versus mental health. First, a definition, and this is pretty key, but just so that you understand, behavioral health is a term that encompasses basically both traditional mental health with a mental health diagnosis and substance use with substance use diagnoses. We lump it all together into behavioral health. And so telebehavioral health is using virtual care, virtual modalities to serve that whole domain of mental health and substance abuse care. So that's the only, if you've seen that word and you've seen it flying around, that's the main take home for that. It's important too to recognize that telehealth is a lot of different things to a lot of different people. There isn't just one kind of telehealth. Hospital and specialty care, integrated primary care, remote monitoring, these are just examples of sort of large domains in which, and methods in which telehealth can be used to do certain things. And then of course, direct to consumer is kind of what exploded in 2020. And that's what we know as telehealth now. But prior to 2020, it wasn't. It was a side thing. It was a piece, a small but growing piece, but it didn't explode until 2020. And the upstart of all of it is that the regulations that we have in place primarily address those top three kinds. And we had only a little bit addressing the direct to consumer kind. We had to come up with a lot of that during the last year. There are also lots of different, or a variety of different technologies available. Live video, of course, asynchronous messaging, secure texting, store and forward, it's called sometimes, remote physiological monitoring, and all of the instruments and devices that go along with that, as well as mHealth, which is just kind of a word for anything you do with a cell phone. So those are all things that you come across, and it's important to recognize there are services and there are technologies, and they don't necessarily line up one-to-one, but they interact in various ways. And then, of course, you got the whole audio only, which is basically a telephone call. Where did that come from? For years, audio only was specifically excluded from telehealth. Now we get it paid for. So that's added a whole new twist. Telemedicine is a delivery mechanism, not a service. You don't refer patients to telemedicine. You refer them to mental health or behavioral health or endocrinology or cardiology. It just so happens that the provider is going to use telehealth to see the patient. So it's a mechanism, not a service, and it's important to make that distinction, especially when we talk about whether it's going to be paid for or not. The underlying service, of course, has to make clinical sense. It needs to be clinically justified and documented as such. And then whether or not it's appropriate to use telemedicine is an overarching or an encapsulating question within the context of that clinical service. Likewise, as I said before, ethical guidelines and regulations apply to the professional equally, although there are a couple of things you need to be aware of, like state boundaries. I'll talk about that in a sec. At the federal level, there's very little that says what you can or can't do in telehealth, other than HIPAA, which applies to all of healthcare, not just telehealth, and the Ryan-Haight Act, which again applies to all of healthcare, Stark Law. These federal regulations apply to all of healthcare. You can't refer to yourself. You can't prescribe controlled substances without seeing the patient, unless you're doing telehealth, which for many years was a sort of a strange and undefined carve out, and it still is a little bit undefined. I'm not going to go into it in depth here, but the primary thing we got at the federal level were Medicare conditions of payment. These didn't tell you what you could or couldn't do. They just told you what Medicare would or wouldn't pay for. And that has changed now because of the pandemic. And this is just a little bit of a lineup here. I'm just going to do a preview of Medicare's changes that are coming, that exist now in 2021 and are coming in 2022, because we are starting to see the tail end, what we hope, I guess, is the tail end of the pandemic. We're starting to see post-public health emergency, post-PHE changes and regulations. And Medicare is kind of a harbinger of those. In 2021, we got an expanded list of covered services. This goes all the way back to 2020. An expanded list of provider types. We got RHC payment limit increases a little later this year. And then we got the location limits removed, and we got audio only coverage for all these services. And we got FQHCs and RHCs as distant sites. This is, I won't go into the details here. This is kind of arcanery between facilities and providers is the hang up there. But basically, the waivers allowed FQHCs and RHCs to bill. Going forward, it's going to be different. So in 2022, we've just now seen the proposed rule. Those top 4 bullets carry over to the new physician fee schedule in Medicare. That's the PFS for 2022. But the bottom 4 bullets are going to be different than the gray ones on the left. Basically, Medicare is going to say there are no location limits for behavioral health. That means substance abuse and related mental health care. They're going to cover audio only for mental health going forward when the provider is video capable, but for some reason they can't provide using video. They're going to be able to fall back, in a sense, to audio only. That's what the PFS proposed changes are. The FQHCs and RHCs are not going to be made distance site providers. They're going to define them slightly differently. They're basically going to say, if you're doing telebehavioral health, you can bill it the same as an in-person encounter. So that's the way they're going to get around some regulatory complexity in the FQHC, RHC space. And then transitional care management, chronic care management, and collaborative care management. Those services, they're just clarifying that you can do those and bill for those in the same month that you're billing for other services as well. And the reason I add them to my list is because within those types of services, the chronic care management, transitional care management, those services have no technological limitations. You can see the patient in person, you can call them on the phone, you can do live video, you can do text messaging securely, you can do any type of communication. You don't even have to have the patient there. You can be reviewing patient data and coordinating among team members. Those are the future of Medicare reimbursement, is those TCM, CCM, COCM, those clinic codes, those care management, that paradigm is the future for Medicare billing. So I really want to call that out and say, if you've got initiatives pointing in that direction, you're starting to learn those kinds of things, or your members are starting to learn to do those kinds of services, I absolutely believe that that's where Medicare wants to go in the long term with its telehealth coverages. Because like I say, in those services, telehealth is not a thing. It's like you decide how you want to contact the patient, just do it for this many minutes every month and bill it. And these are the things you can do, but you can use any technology you want. So that's the federal level. Now let's go down to the state level. Of course, at the state level, that's where most telehealth regulation, as far as what can and can't be done, exists. And the place that it exists is at the licensing board. Telehealth is primarily regulated through licensing boards. And that's why your providers are all nervous about it, because it's their license that's on the line. Now, there are also state laws, and there are increasing state laws about who has to cover telehealth and what it's defined as, what sorts of services have to be covered, all of that. Minnesota just passed a raft of those in the omnibus budget bill, which we're very happy about. But those are the kinds of things that happen, and most regulation and most coverage issues happen at the state level. Medicaid reimbursement and commercial payer regulations. There are proposals at the federal level that state licensing board, and some states have already passed this, saying licensing boards, you need to talk about telehealth in your regulations, because it's a thing. Your providers are doing it. You need to have standards in your guidelines, in your standards. And there are licensing boards that up until 2020 didn't and still don't. And so they're being pushed in that direction. There are a lot of new definitions of telehealth, and various disciplines that are taking up telehealth. Physical therapy can now do telehealth, at least at the federal level. And so states are having to say, well, are we going to allow that here too? And then we're going to pay under Medicaid. And what does that look like? And there are definitely ways that they are doing that. So we are still in a time when there's a lot of impetus to make sure those services get covered and reimbursed, but there's going to be a lot of state variation there. Remote monitoring, audio only services, coverage parity, and parity for audio only. Those are all things that are going to be hashed out at the state level in Medicaid and for commercial payers, just like they are for Medicare at the federal level. Your mileage may vary. I'm dating myself probably with that quote, but that's what was on TV when I was a kid. And check with your regional TRC or another informational source to stay up to date on that. You really should have an up-to-date informational go-to source, because those are the kinds of things that do change a lot. Just as an example of those kinds of sources, GB Track. For our region, we have billing guides, telemedicine billing guides for each of our states. This one says Iowa on it, but we've got them for all of our states. And they provide up-to-date. They're updated as the rules change once a month, or as needed, they get updated as the rules change about billing, and they cover commercial payers as well as public payers in our state. And you get these matrices about, who's the payer, what's the service, how is it billed, whether it's allowable. It's just a lot of detail. And unfortunately, this is kind of how telehealth is and is going to be for the foreseeable future, until we get more unification and alignment of telehealth billing practices. It's not overwhelming. And once you figure out what it is for your major payers in your definitional, who you are and who your major payers are and what kinds of services in what state, once you kind of get that down, then it simplifies. Obviously, there's just one column that you're following, or just a few squares that apply to you, and then you know that, and it's not as dizzying as all this. But but it is a little bit disorienting at first. And so that's why I say, reach out to a TRC or somebody who can help you navigate that initial learning if you haven't already. The other thing that's going on, and you all are aware of this, certainly healthcare is as changeable a field as exists, but the definitions of telehealth have changed an awful lot. It used to be always live interactive video. Every now and then, store and forward or asynchronous telemedicine. Telephone, fax, and email were always excluded by every rule. Not anymore. They were, not anymore. Fax and email, although secure messaging is a thing, telephone is now covered, audio only. So there's a lot of change going on. And I think it's important to recognize that almost every telehealth provider is doing some service. Almost everyone, the majority of the telehealth services they're doing are only reimbursable because of flexibilities since the pandemic started. We suspect a lot of those flexibilities are going to they're going to be put into law, put into regulation going forward, because there is such a tremendous demand, both among patients and providers, to maintain some of these services. But of course, there's a tremendous pressure on payers to figure out what are the policies around this. Are we just going to pay a full PPS rate for a telephone call? Are we going to pay a full, a fee-for-service rate for a text message, or a 10-minute phone call, whatever? And they're having to figure those things out, and they're gradually settling. Medicare has in the new physician fee schedule has sort of made the first set of outlines about what that's going to look like. We had a lot of what I call leveling during the pandemic. Like it's like in California where I grew up, there were these reservoirs in the mountains that were basically filled in valleys. And when they would get really low, you could see the tops of little hills poking through, right? But as the water went up, then the hills all go away and it's all just one flat surface. And in the same way, as policies during the pandemic shifted, the water rose, and it looks like the policies are the same for everything. Audio only, you bet it's covered. Direct to consumer, you bet. At the patient's home, you bet. Urban, rural areas, all of it. Yeah, it's all covered. As the pandemic recedes, we're going to start to see, now this payer doesn't pay for that anymore. And this payer is not going to allow this provider anymore, this provider type, or that location. And so you're going to see these islands start to appear again, and we'll see how that looks as those temporary rules get rescinded. Again, another reason to stay in touch. All right, I'm just going to say a little bit about some of the operational details. The main point here is that there is no one way to implement telehealth or telebehavioral health services. I'm a clinical psychologist. I've worked in telebehavioral health my whole career. There are lots of different ways to implement telebehavioral health services, and it's because they are just, as I said, telehealth is just a tool, and the services are designed and staffed and planned and paid for in a different way at one site than at another. We have two FQHCs 50 miles apart in northern Minnesota. One of them implemented telehealth and it's working great. The other one is starting to implement telehealth, and they're saying, we can't do it that way because we're not staffed that way. And so they're having to figure out their own way to do it. Well, you would think these two, same legal definition, same state, same coverages, all of that, we could just say, well, do it like these guys do it. Just copy their program. And in fact, no, they have a different staffing model, and so they can't do it exactly the same way. And so all of us TRCs have kind of realized that we can't just tell you, here's how you do it, 1, 2, 3, and push the button. It's not a copy and paste. It is a bespoke service. And so what you have to do is be aware of who all is involved. How do we do services now? And how can we effectively implement telehealth services? And it means workflow analysis is a big piece. And so I'm just going to touch on it. It's not key. It's not absolutely essential, but being aware of the kinds of things that make workflow analysis work, like including everyone who has a meaningful role, making sure each person is part of the process, paying attention to decision points and forks and branches and how people are handed off and who's going to cover that. These are all just basic parts of doing a workflow analysis, and I don't need to train you on that. I don't mean to train you on that today. This is an example of a swim lane workflow document that just shows some of the things people end up including in a workflow analysis that includes telehealth. So for example, behavioral health visit is needed, contact the patient and schedule it, make the appointment. If there's no appointment at the end, if they schedule it, then inform IT so that IT knows, complete the forms, and then pass it on. IT does sets up a Zoom account, or because they're using Zoom in this particular instance. On the day of the visit, they connect with the patient. They have daily things that occur every day at the beginning of each clinic day. So it's not really part of the flow, but it has to happen continuously. So you have that in your workflow analysis. When the process gets down to the rooming person, down to the provider, and it gets to the end, then what? We close Zoom, but we have to recycle back here and schedule the next visit. So it goes back to the top again and starts over, because this is not just a process that happens once and is done. And then also some of these points here in the flow could be varied, so that you could open the EMR once you're connected with the patient, or you could open that ahead of time and have it sitting open, and the patient could connect directly, and you're already waiting as a clinician. The clinician is already waiting. This is just to give you an example. This is not the workflow for telehealth. This is a workflow for telehealth, and it relies on a certain clinic structure, and it is based on what they do in that clinic. So you'll have access to these slides. You can get them from the organizers or directly from me. I'll show you my contact information here in a bit. But you can use that as a starting point if you want to. The point is, it's going to have to be yours. There aren't a lot of shortcuts other than understanding your own process and then understanding how you're going to work telehealth into that process. And again, we can help you talk through that. We can help you develop those kinds of diagrams as well. And everything we do is free, like I said at the beginning. When you're working with patients who are a distance away, you got to think through your emergency procedures, because you cannot lay hands on them in an emergency. You can't intervene, you can't inject, you can't do something to, can't even give the Heimlich. You can't touch them physically. So as part of the initial session, you are discussing emergency procedures. You are collecting information that you may need, like local fire and police, because if you pick up your phone and dial 911, it's going to ring your 911, not necessarily theirs if they're, a couple of counties away or in the next state. The main goals in an emergency situation are to maintain contact with the patient and transfer care to an appropriate on-site responder or caregiver. It might be police when they arrive, it might be ambulance crew, it might be a parent in the next room, a neighbor, could be anybody, but you're going to have think through what resources you want in place if the patient, God forbid, starts choking. If the patient, if the ex is banging on the front door all of a sudden, oh no, he's here. What are you going to do if you're in a session with the patient at that point? And you can't just say, ooh, looked like a dangerous situation, so I hung up and hoped for the best. That's how I'm going to write my note afterwards. No, you can't do that. You have to have some sort of a plan, and hopefully you're not making it up at the time. So think through how you're going to responsibly transfer care to an on-site responsible person if something happens. Panic attack. I supervised a clinician who was working with a patient, and she had a panic attack. The patient did. Nobody was in the clinic. It was after hours. The patient had made special arrangements to come in after hours. There was no one on site that the clinician could call. She ended up having to talk the patient down from panic attack, and it was quite harrowing on both sides. So think through those kinds of things. They don't happen often, but you should have some sort of a generic plan in place on how to transfer care and make any kind of reports that you have to. I also highly recommend at the operational level, developing and using scripts. Hello, Mary, I'm Dr. Smith. Can you see and hear me clearly? Adjust anything you need to. Okay, as you know, I'm Dr. Smith. Can you confirm your name and date of birth for me, please? I know we do this all the time in healthcare. I know I just saw you last week, but just humor me here. It's what we do. Can you confirm your location? Looks you're at home in your bedroom like usual. Okay, sounds good. Then you know where to call, right? If an emergency arises. All right, is it private? Is there anyone else in the room or within earshot? you have any questions about the privacy of this call, we're reaffirming our informed consent. Are you fully informed, and do you fully consent to doing this encounter? If we get disconnected, you remember you need to call this number, or I will call you on that number. We'll try and reconnect twice, and then we'll try by phone, or whatever your procedures are going to be. And I can give you some examples of what other places have done, but it's really going to be a little bit of trial and error and a little bit of planning on the part of your staff to figure out what your script is, or what your scripts are. You're going to use them at various places, but I highly recommend having those scripts in place. All right, last couple of things. Clinical skills, and I'm just going to breeze through this. Bandwidth is everything. It's the water under the boat. No matter how fancy your boat is, if you don't have bandwidth, you're not going to be able to do much of a telehealth encounter. You don't need a lot of bandwidth, but you do need it to be consistent. Same thing, framing yourself in the screen. Get your eyes up toward the top and the camera down close to the top of this TV, because the impression of eye contact has everything to do with the distance between where the patient is focusing and where the camera is. So you can't control all of this on your end. The patient controls a lot of it, but you can at least recommend to people that they do that. So you can see in these examples the discrepancy between where the eye contact and the camera. I don't know what's going on there. It's just kind of silly, but here the camera's looking here, but he's looking down at the patient. So that large angle there's not going to be any sense of eye contact. This one actually, is as odd as it looks, is the good example, because where the patient is looking at the provider's face and where the camera is looking back, that's a very narrow angle, and it's going to look like he's making eye contact with the provider. And likewise, if the patient is framed appropriately, likewise on the other side. So those are just some things to be aware of with terms of eye or camera geometry. As far as your presence on the screen, spend a little time looking at what you look like on the screen. What's your background? Is it more interesting than you? You want it to be fairly muted. You don't want it to be spare or blank, although that's nothing wrong with that. But you don't want it to be overly distracting. You want to fill the frame to the top. You want to be toward the top. When you're doing a webinar, maybe you need the top of your head. You don't want to cut off. But when you're doing clinical work, the top of your head has no information. Keep your eyes to the top, even if you cut off a little of your head, because you want it as close to the camera as possible. I make sure that my hands are on screen because I do a lot of gesturing. And when I'm gesturing, I make sure that I can see my own image so that I can, keep my fingers, my hands in the frame as I'm gesturing, so that I'm not gesturing off screen here, doing all kinds of interesting things that you can't see. So, and I didn't talk much about lighting, but those are just some basic kind of clinical presence issues. I've done a kind of a whirlwind tour here of telehealth. I hope you have some questions. I'm going to turn it over to Evelyn at this point, and then we should be able to have some questions to follow up. This is my contact information. And again, you can reach out to me if you want these slides, or if you want to follow up with us, or for whatever reason you have questions. With that, I will turn it over to you, Evelyn.
Super, thanks, Jonathan. That provides a really fantastic presentation for any telehealth. Really having that foundation and checking all those important boxes is essential. I'm going to give a really quick sneak preview of our next sessions. They'll talk some about how does this foundation look in different situations. I'm fortunate in the next session with Robert Stiles, our director of Telehealth Rocks, our school-based telehealth program, to talk some about how does a program with primary care look for kids, and then how does it look for adults. You outlined the need very well in your presentation. I think when we're looking at rural primary care and the projects we've done telebehavioral health, we're really looking at our highest need underserved areas across behavioral and developmental services. So across psychiatry, psychology, developmental medicine, nutrition, there's so much work that can be done, and really it gives us that window to be able to do that. In behavioral health, we of course talk about the 20/20 rule with kids. So about 20% of children will have a diagnosable behavioral health concern by age 18. Only about 20% of those children receive any type of specialty service, let alone from a child specialist. Of course, those numbers are greater now with the stresses and strains that we've seen through the pandemic. So it's awesome to hear what you're talking about with the extension of some of the different types of telehealth modality. And we're also so lucky to have good treatments for behavioral health with kids. So the technology, again, is that mechanism to help us meet those really good services with our high need, especially in our rural communities. I got into telehealth because of the access and being able to meet that need. What we'll talk about some at our next session is sometimes I think telebehavioral health can even go above and beyond. It can also be a wonderful systems connector. So it helps, of course, meet the needs of the students and families, but connect the student and family specialists, educators, and rural primary care all together. And we'll talk about how some of those logistics look. This is our overall Telehealth Rocks model. And again, Robert will describe all these components. Kind of the idea is we focused a lot on the direct clinical services today. As soon as we start offering direct telebehavioral health, pretty soon comes the staff and the professional leads. How can I have more education about that? How can I know the warning signs so I can support the student? So we're really using the technology for both the education and the clinical services. And then our program is reaching down more to prevention services and family engagement, which Robert will describe more in our next meeting. We'll also talk some of about an adult primary care focused program with our state's largest accountable care organization. It looks across 11 rural primary care sites within that system. And we'll talk some about the implementation. What did those workflows look like across those 11 ACO members? To date, it's been around 250 patients across about 1,100 encounters. We'll talk through some of the benefits. I think, we really see the benefits for the patient and rural primary care, but also with the ACO, what's some of the facility benefits? How can telebehavioral health complement some of the new value-based care goals that the ACO members have? That project really focuses again on what's the behavioral health needs within primary care. So a lot of depression, anxiety, and then during the pandemic, just a lot of need around grief and adjustment, and how does that look like over telehealth? We'll talk a little bit about evaluation and looking at what kinds of metrics we want to think about with telebehavioral health programs. And then some of the resources through our national consortium of telehealth resource centers. I also put some of our Heartland Resource Center resources around billing and coding that might be of interest to the group. So again, just a quick teaser. We hope you'll be able to join that next session.
Great, thanks. Any questions for our speakers? Terry?
Nicole, I'll start off. Yes. Jonathan, we have a variety of different state flex coordinators on this call. And I'm wondering what would be the best source of information on exactly what is happening in their state. Because from what I understand, almost on a state-by-state basis, there's a tremendous amount going on with their Medicaid programs, sometimes even in the private insurance basis. So would the TRCs be the place to go, or is there any central kind of clearinghouse on what is going on?
Yeah, thanks, Terry. First of all, I wish it was better. I wish there was a better source, or that, and we're trying always to get better. I know the TRCs are trying to get better. The challenge there is, of course, there's not one answer. There's 50 answers, because each state is going to have its own sort of folks or groups of people that are following closely. TRCs would be a good place to start, because all of us keep track of the states in our region. There is also the policy TRCs, CCHP. They are at cchpca.org, or you can get to them through telehealthresourcecenters.org. Thank you, Nicole, put it in the chat for us all. They keep track of policy for every state going forward, or on a week-by-week basis. They're constantly monitoring that. Just so you know, though, there are two weird things that happen. Number one is that in telehealth, and we're hoping that these gradually improve, but number one is not all policies are written. It's kind of a weird thing, but we found this a lot pre-pandemic with FQHCs. There was just no policy about how FQHCs get paid, or there was a policy about what they could and couldn't do, but do they get a PPS rate for that, or is it fee for service? Well, or can we do it if we do site between two FQHCs? How do you bill for that? Because where's the originating site? Where's the distant site? It just was never written down because no one had gotten into it at that depth. So that happens. The other thing that every now and then happens is that there is just no policy, or the policy is there are conflicting policies. There are either gray areas or areas of outright sort of conflict that cannot be reconciled. And again, it's just because we haven't ironed out all of the kinks. So every now and then you run into a policy hiccup, but the best place to start, I think, is probably the TRCs. Other good opportunities, if you've got a really strong rural health association, of course, a hospital association that has a big CAW component. Various states are going to have various resources. The resources are going to vary in this regard, but any place that has a policy person or a a government relations person that's active and engaged is going to be a good source for a lot of this.
Thank you.
Okay, comments or questions from anybody else? Okay, I guess
Hey,
that's it.
I'll jump in with one more comment, and that I really want to promote that next session as we look at what is it of substance we can be doing in the area of population health. This connection between our clinicians, our hospitals and our clinics and our schools, to me, is just so incredibly important. And the program that the University of Kansas Medical Center has put together that we're going to hear about tomorrow really provides that sort of a connection. And what, as we've gotten a preview of this, Nicole and I have, we're just really excited about the possibilities, not only to benefit the children and the patients, but to start building those bridges between the schools and our healthcare providers as well. I was extremely impressed with what is going on. And in my opinion, we need to have something like this going on throughout the country. So, again, I just want to promote that, kind of tune in for that program. And again, we didn't mention it here, but behavioral health and, mental health in general is at the top of the priority list for rural America, for everything that we're seeing right now, is that we have this immense problem of mental health, behavioral health in our rural areas. We have a huge scarcity of resources that are available. And we have a solution here And I really think it's important that particularly we start with the youngest, members of these communities and find ways that we can support them early on. My wife is a third grade teacher, and she basically said, if I had access to this sort of a program, she said, my work would have been so much simpler. It would have been a godsend for me as well. So I just wanted to put in that word. We're doing some really cool things with telehealth services, and this is certainly one of them.
Terry, I just wanted to say, this is Robert, and I've worked a lot in helping people get access, and I recognize when you're talking about the Flex program and you're talking about critical access hospitals, you're talking about rural health clinics, we can talk a little bit about sort of workarounds, because I think sometimes those in that group don't think they're going to be able to do it. They're not an FQHC, they don't get all the same abilities, but there are ways to do it, and I've helped hospital systems and critical access hospitals and frontier communities do this. So I know we have to go, but I did want to say that we'll make sure that it actually applies to the Flex programs in terms of really talking about the type of entities, obviously, that are involved with the Flex program and how it can work and be incredibly successful for those types of entities.
You guys can totally keep talking. We've got 3 more minutes. We just wanted to throw up those post-content polling questions. So if you would all just take a minute while you're listening to the closing conversation to answer those, that would be fantastic.
I just really wanted to point that out because I understand the frustrations. I was in the rural health office for the state of Kansas for a decade. I mean, I understand this, and we want to make it especially useful and something that can be implemented. And we can talk about how people have worked their way around some of the barriers, right? You can't set up a rural health clinic in a school, not very easily. Like an FQHC can set up a site, but you can do lots of other things, and actually telehealth can be easier to do down a physical location out in the community. So certainly talk about that. I'm excited to talk about that because I hate to see anybody not realize they can do it when their community needs it.
Yeah, and also for the webinar next month, I will see what I can find out is happening in our Flex programs, like who's already supporting these sorts of initiatives so that I can share those examples with you and hopefully have a Flex program or 2 even talk about what they've done to support behavioral health in their states and their hospitals.
And I would encourage people to bring the problems people tell you why they can't do this. And I'm happy. I've spent 20 years now helping people figure out their way around what they think are the barriers that let them do it. So happy to take on your biggest problems.
All right.
Nicole, there's a question in the chat about registering for the next session.
Yeah, so these sessions, these live sessions are really, our intended audience is state Flex programs and state offices of rural health. If you are part of one of those, please feel free to send me an email because I would love to get you added to the email list. That's how we communicate these things and the events on our website. So really we're for that intended audience, but the playbacks are always available on our website as well. So they usually take about a week to show up on the website. I'll put my email in the chat though for anyone that needs it. Okay, I think we are good. Any follow-up questions? Jonathan mentioned his contact information was on his slides. We will put those slides on the website with the recording. You all can reach out to me. You know where to find me, and I will connect you with our speakers and any other resources that might be relevant to what you're looking for. So with that, we will close this out, and I will be in touch with all of you to let you know when part 2 is going to happen. It will be sometime in September. So with that, everybody have a good day. Thanks.